Thank you, everybody, for joining the NYACP meeting today on Elder Abuse 101, focus on the shelter movement. We're so grateful to have Malya, Levin, and Meredith Levine with us today. Next slide. For those of you who are not aware, NYACP is a statewide organization. You're just testing to see if I remember what I'm involved with. It's a statewide organization for internal medicine and its specialties. It's the largest specialty organization in the state and represents over 12,000 IM physicians. Upcoming events, in March, we have small feedings of the soul, and then the Women in Medicine series starts, so please be on the lookout for those great programs. I also save the date for the annual meeting in October in Tarrytown, and so don't miss out on that opportunity. So one of our speakers, Meredith Levine, is a social worker, a senior elder justice specialist at the Weinberg Center, an advocate for trauma-informed practice and advanced care planning, got her master's in Columbia, and was a fellow of the Hartford Partnership, is board certified in palliative and hospice care, and is a graduate of NYU's Leadership Fellowship. So it's great to have her here. And also we have Malya Levin, who is the Assistant Director and General Counsel at the Harry and Jeanette Weinberg Center for Elder Abuse and coordinates Westchester's Elder Abuse Multidisciplinary Team, and was named one of New York Jewish Week's 36 under 30 and went to Brooklyn Law School. So go Brooklyn. No planners or anyone else in control of content have any financial relationships with ineligible companies. I know faculty have any relevant financial relationships with ineligible companies. These are the members of the Education Content Validation Committee. If you missed it, too bad. And we are going to very briefly show the QR code, but we will show at the end of the presentation the link, and we'll send it in the chat so you can log in and get your CME for today. If you have difficulty logging in or creating an ACP password or username, just reach out to me or Isaiah and we will help you get through it. And there's lots of other ACP information online, so you could check out the Online Learning Center at this webpage. And that's it. So I'm going to, which of you is going first? See, I'm learning. All right, I'm going to spotlight you. And thank you again so much, both of you, for being here.
Hi, good afternoon, everyone. So happy to be here. Thanks so much for this opportunity. Great to speak to you all. As Paula, Dr. Lester already said, I'm Malya Levin, and I'm the Assistant Director and General Counsel at the Weinberg Center for Elder Justice at the Hebrew Home at Riverdale. And what we really want to talk to you about today is focused on the unique model where Meredith and I both work, which is an elder abuse shelter, and the unique way that our shelter is created based on the unique needs that people who experience elder abuse have, the ways that we provide services, and sort of some of the unique nuances to those services that are really based on how elder abuse really looks quite different than other types of violence across the lifespan, and how our shelter model is really responsive to those unique needs. So, Meredith, are you controlling the slides? If you could, or whoever could go to the next slide, that would be great. So these are a few images. That larger one is our campus. This is the Hebrew Home at Riverdale. We are part of River Spring Living, which is a large healthcare organization that provides serves over 18,000 low-income New Yorkers across New York City and beyond every day. This campus is where a lot of our services take place. Our congregate care services take place. On this campus, there is rehabilitation, there is long-term care, there is Medicaid-assisted living, as well as a private assisted living, as well as an independent living. This is all located on the same complex along the Hudson River in Riverdale. Now, what does this have to do with elder abuse, you might ask? Well, this is also the site of the first elder abuse shelter in the country. The genesis of this idea was that our founder was an attorney like me, and she actually was a prosecutor in the DA's office in Manhattan, and she prosecuted elder abuse cases, among others. And what she saw was that older people would often stay in unsafe situations, remain living in unsafe situations with the person who was causing them harm, because they simply had no other safe place to go. And when I say no other safe place to go, I mean they couldn't afford to move. They often might have, a unique housing situation, particularly in New York City. People who have lived in the same place for a long time often have, especially who are older, often have very valuable housing, which at very low costs because they may have rent control, they may have rent stabilization, they may own their home, whatever it is, it's not so easy to pick up and move. They basically have an invaluable situation. They need increased levels of care or assistance in their home due to nursing needs, potential cognitive related needs. They're familiar with their neighborhood, their living situation. It's easy for them to navigate that, and it's not so easy to just pick up and move. And the places where people might typically go on an emergency basis, if their home is not safe, like a domestic violence shelter or even a homeless shelter, just can't accommodate the types of medical and social and professional assistance that older adults require, that just aren't the same across the lifespan. And so our founder was seeing this with the people who had experienced harm, you know, who, who were involved in her prosecutions, who were complaining witnesses in her prosecutions. And she was thinking about where there might be the opportunity to create a unique shelter to serve this population. And she happened to meet at some sort of professional networking event. She met the CEO of the Hebrew Home, Dan Reingold, and she kind of described this dream to him. And he said, we could do that at the Hebrew Home because we already have in place so many of those services that older adults need. We have rehabilitation, we have geriatricians, we have dietitians, we have OT, we have PT, we have speech, we have dentists, we have all these people who all they do basically is serve older adults. We have this whole community with socialization opportunities unique to older adults, and it already exists. And so let's put shelter in place as an additional layer on top of this already existing community for older adults. And so that's what we did in 2005. We opened our doors, and actually, you can move to the next slide. So taking a step back for a minute, and we talked a little bit about this in our last presentation, but for those who may not have been there or who need a refresher, when I say elder abuse, what I'm talking about is something that, there's no real one official definition for. There's no crime. I'm a lawyer, so I think about legal definitions or the criminal code, the penal code, civil harm. There's no crime called elder abuse in New York State. Different professional organizations have different ways that they define abuse. We usually use this definition that was promulgated by the Centers for Disease Control. And the reason that we like this definition here, and I won't read it because you can read it on your screen, is that it really highlights, first of all, that there has to be some kind of intent to cause harm, or the risk of harm. Very often, older adults may be living in unsafe situations because the person who's trying to care for them is an older person or a frail person themselves and really can't care for them appropriately. Or they have a risk of harm because of their own, a mental health situation that they're struggling with, some kind of, some kind of disorder that they're struggling with that they can't manage alone. We wouldn't call that abuse. Their abuse really requires intent by a third party to cause harm or the risk of harm. And also, who is that third party? Well, it's somebody who's in a relationship involving an expectation of trust with the older adult. So it's not a random mugger or carjacker or some other person who commits a crime and the victim happens to be an older adult. It's a crime that really is not necessarily a crime, but it's harm that is committed by exploiting a relationship of trust. You can see some statistics here about sort of the incidence and prevalence of abuse. We know that it's quite prevalent. The worldwide statistic is 1 in 6 people 60 years and older experience this, some form of abuse. The statistic that's generally cited in the United States is about 1 in 10. But either way, it's quite a common problem. So these are the people who you're seeing. If you're seeing older adults in your practice, if you're seeing them in a hospital or in private practice, wherever you work, you are seeing people who are experiencing abuse. I mean, just statistically, we know that that's the case. Now, do you know it? Probably often you don't know it. And why is that? Well, because it's dramatically underreported. This study that was done, that's pretty old at this point, in 2011, says that for every reported case of abuse, 23 more go unreported. That was a New York State specific study that was done really exclusively surveying older adults in New York State. And the noteworthy thing about that study actually is that it was done through self-reporting, through telephone interviews that the researchers were conducting with older adults in the state. So if you think about people who couldn't participate in telephone interviews, maybe because they had speech difficulties caused by some kind of medical issue, or perhaps because they had cognitive impairment, their numbers or their incidence of abuse isn't even included in this study. And we know that those people in those categories are some of the most vulnerable to abuse. This one small study in the British Medical Journal shows that close to 50% of people with dementia experience some kind of abuse. That's a huge, huge number. It's very hard to study this particular population for reasons that we'll talk a little bit about, I think, a bit more later in the presentation. But it's very hard to detect if you're seeing somebody in front of you who's experiencing abuse. And abuse nearly always, besides for a physical component, abuse can have a physical component. It almost always has an emotional or psychological component. It can have a sexual component, but it nearly always has a financial component as well. And we see that $28.3 billion in annual losses to financial exploitation. That's a statistic from the AARP. I know Meredith said in our last presentation, and I agree, sort of every time a new one of these studies comes out measuring the amounts that are taken from older adults due to financial abuse, the number seems to be exponentially higher than it was in the last study that was done 2 years earlier. So we're really uncovering more and more, but this is a huge, huge issue that really often is going undetected. Next slide. So going back to the Weinberg Center and what was founded in 2005, like I said, when our founder met the CEO of the Hebrew Home, what was done was we took this pre-existing infrastructure that existed, this medical team, rehabilitation services, nursing care, therapeutic activities, which all, again, already existed at the Hebrew Home as part of the short-term rehab, long-term care, assisted livings that already existed. And we said, let's use this as a shelter to temporarily house older people who need to leave their homes on short notice because they're experiencing harm in those homes. Because elder abuse by its very nature involves this expectation of trust, the most common people who are causing this harm are often family members. So it can be an intimate partner, it can be a child, a grandchild, another family member. But so often, again, home is unsafe. And so have an older adult come in to our facility, and our the way that our shelter model works is that it's virtual. And what I mean by that is you saw that aerial photograph of our big campus. There's no one building or floor on a building on the campus that is the shelter. The whole idea is that older adults have a quite varied medical needs, depending on their cognitive status, depending on what types of chronic conditions they may have. And so people who need shelter are placed throughout the campus, wherever is best for their medical needs. And Meredith and I are part of a small team, the Weinberg Center team, which includes lawyers like myself, social workers like Meredith, a public health professional, and we're sort of like a little SWAT team going around to wherever our clients are located throughout the campus and providing, in addition to all the sort of standard services that they're getting, trauma-informed social work services, trauma-informed legal services that are specifically geared toward addressing the abuse the older adult has experienced. And a lot of the way that we address that is around figuring out how to get the person back out. We know that a lot of people don't want to stay in nursing homes long term. Nursing homes are very stigmatized, and we don't want to keep anyone at the Hebrew Home long term if that's not where they want to be. So a lot of our legal work, a lot of the trauma-informed social work and case management that's done for our clients is with an eye toward Where can they go? Can we make the home that they came from safe? Are there legal tools that we can use to remove the person who caused harm? Is there another place that this person, that the older adult would like to go? Can we help advocate for them to go to that place? Can we plan with them for their continued safety once they go there? So a lot of our work is geared toward ensuring that the person is ultimately ending up, once they leave our temporary program, in the place that they want to go and in a place that's appropriate, that can serve their unique clinical needs. So next slide.
Sorry about that.
No problem.
Oh, I think this is our video.
Oh yeah, so this is a video that will depict the story of one of our clients going through the process that I just described, and will hopefully, give you a little color of and a sense of what we're talking about when we talk about the shelter program.
My name is Janet Jones and I'm 70 years old. I'm born and raised in Coney Island. The Hebrew home is nice. It's a nice place. Very nice place. I've met new people, nice people, at the Hebrew home. Nice people.
Janet was financially exploited by her daughter-in-law and granddaughter while they were living in her apartment in Brooklyn.
The Weinberg Center takes care of people who have experienced harm, and oftentimes that harm is perpetrated by people in their own family.
These are not strangers. These are people that she trusted and loved.
I had a stroke, and she was taking my money. My daughter-in-law. That's my grandson's mother, you know what I mean? It is what it is.
Reporting elder abuse by loved ones is very embarrassing, and because of that, people don't tend to be vocal and don't want to participate in any kind of prosecution, but Janet was definitely different, and despite everything, took a part in getting her own justice, which is amazing. She's quite remarkable.
For someone like Ms. Jones, whose desire is to return home, the things that we do are pointed in that direction so that we can help her get exactly what she wants.
Janet has definitely received a lot of emotional support, as well as rehab services that she didn't have the opportunity to receive before because of the abusers and their interference. So I think that when she goes back home, she's physically stronger, as well as mentally stronger.
I want to do a little bit of everything I used to do, I know I can't do everything I want to do, but I had therapy already. They treat me good. I can't say nothing about that, but I want to go home.
I don't know, I had that many clothes.
You on your way home, sweetheart?
Yes.
Okay, I'll see you then, okay?
Okay now. Love
Okay,
you.
baby.
Love you.
Thank you so much.
I'm gonna miss you, Rita.
No, I'm gonna miss you.
Love you now.
I love you.
Shelter is an integral part of a coordinated community response.
Goodbye, sweetheart.
But we need other people to really help us get people back home safely.
Oh my God, I miss you, darling.
The apartment was completely redone, freshly painted, new cabinets. She literally will be going back to a new apartment.
Let us know how you're doing.
We wish you all the best.
She has family, but she also has people that care for her that aren't her family.
But look, you're going home.
Oh yeah. Oh yeah.
Really just showing that all disciplines, when they work together, can really accomplish something great, and her great will be going back home.
I feel a little better now, you know. My life is a little more straightened out.
Congratulations, you're home.
I'm glad to see you.
I'm glad I'm home, I'm gonna tell you that, boy. Oh boy.
Janet allows us to look really in the face of what an elder abuse victim might look like. Elder abuse affects 1 out of 10 older adults. Janet really gives us hope that even older people who experience abuse at the hands of a loved one can heal and return to life.
I love that video. And having worked with Ms. Jones quite closely during her time and at the home, I think it really illustrates a lot of what I was already talking about. And the ways in which, in a lot of ways, I think like Ms. Jones was saying, she experienced what anybody who comes into the Hebrew home for a short term will experience. She had rehab, she received care, which she was saying repeatedly was good. And, she sort of had that clinical level of care, but then she also had our team of attorneys and social workers who were working for her and with her to figure out what does she need to address the abuse that she experienced, and then also to move on with her life in the way that she wants. And if anyone's ever worked on trying to get somebody home where there's really no family or responsible party to rely upon, no real funds available, it's super. And on top of that, coming from having experienced a crime and ongoing abuse from loved ones, there was so much intensive services that were required to make this case go the way it did. And again, this is all being done where a lot of the infrastructure are all, fixed costs, things that already exist and are already happening. And so, to give one more person rehab, one more bed, one more meat, one more breakfast, one more lunch, one more dinner, these are sort of incremental costs that are a lot lower and a lot more efficient than creating a standalone shelter for people who have this type of clinical and medical need. Our shelters, beyond providing direct services, we also provide trainings like this one that you're participating in now. We do trainings for a variety of professionals. We have legal initiatives in the courts advocating for elder justice in various ways, educating different groups of legal professionals about elder justice and elder abuse. And we also we do a lot of work replicating this model in communities around the country where we feel really wherever there's elder abuse, which is everywhere, there's a need for a shelter like ours, although each one looks different depending on the community. And I'll get into that a little bit later. But now I'm gonna, I think, turn it over to Meredith.
So how does someone like Miss Jones get to the Weinberg Center? It starts with a referral, and in Miss Jones's case, her mistreatment was discovered by a loved one who had been trying to reach her and calling her, and finally was able to connect with her over the phone. And then he took initiative and called Adult Protective Services. Adult Protective Services came into the home, realized just how dangerous it was for her, and initiated a transfer to the Vulnerable Elder Protection Team, which we have listed on our resource slide at the end of this presentation. But just briefly, it's a team of professionals, doctors and social workers at NYACP Weill Cornell who operate an elder abuse emergency room. And so Miss Jones went there. She had a medical evaluation, and then I think the team there was very concerned about discharging her right back home or discharging her to another facility where she wouldn't get the legal and social support that she really needed to achieve her goal, which, as you all heard, was to return back home. So the Vulnerable Elder Protection Team called our referral line and placed a referral to us, and Weinberg Center staff as soon as we get a referral, we're gathering information, but also identifying the client's goals and already planning how we can achieve them. So Miss Jones was admitted to our shelter program, and we already had a good idea about what her goals were, but we had to assess what barriers there were. And I think with Miss Jones, some of them are very clear. Like, she had some pretty heavy support needs that she would need back in the community. She also had 2 people in her home who were harming her and needed to somehow be removed from her home. And our great lawyers were able to help get orders of protection against those family members. They were removed from her home by the police. Her home was cleaned out with assistance of Adult Protective Services and the social workers here at the Weinberg Center. And she was eventually discharged home with appropriate home care. And also people in place, like the family member who had called, who can help her down the line with medical decision-making and also financial decision-making. And if you remember from the video, that took 12 months to accomplish. So it's not a short process. It takes a while and a lot of commitment from the interdisciplinary teams at the Hebrew Home, as well as the Weinberg Center team. So Malya was talking a little bit about how a traditional domestic violence shelter or even a homeless shelter is really not a good fit. And you can try to imagine what that would be like for someone like Miss Jones to navigate. I think it would be next to impossible. But it raises a question: is elder abuse domestic violence? Should we consider it domestic violence? And sometimes it is. You know, sometimes we see folks who have been in an intimate partner relationship that has domestic violence for many years, but they age in this relationship and they gain new frailties. And so, you know, what a domestic violence situation looks like when you're 20, 40, 60, 80, it's very different, right? You know, a push when you're a younger person has different ramifications than when you're someone who's much older and, you know, could sustain a hip fracture from something like that. And again, you know, we always try to, even when a person has a cognitive impairment, we always try to take what they're reporting to us at face value. We don't have this study listed in this presentation, but there have been bruising studies that recognize that older adults can accurately report when a bruise is from physical abuse 90% of the time, regardless of cognitive impairment. So we always want to be mindful of taking people at face value with what they're saying. And so I think Isaiah put in the chat a link to an image that's on our website. It's kind of unwieldy to put into a PowerPoint, but I think it's an interesting tool to talk about, especially when we think about the tactics people use when trying to harm someone who has dementia. And so this is a power control wheel for people with dementia that we developed a few years ago. And you may be familiar with power control wheels. The first one was created all the way back in 1984 by the Domestic Abuse Intervention Project. And it's really kind of like a simple graphic that's used to describe relationships in domestic violence situations and how one person uses power and control to harm the other. And these wheels have been adapted for various populations. If you did a Google's image search of power control wheels, you'll see them for all sorts of people. And this is one that we created really to describe the tactics that people are using to harm people who have a dementia diagnosis. And so we're going to start going clockwork through the wheel. And kind of the topmost section that you'll see is cognitive privilege. Using bias to diminish the person's sense of capability or negatively influence the opinions of others. And that's really looking at, you know, the privilege someone who does not have dementia has on like a societal level and how they can use their standing in society as a fully capacitated person to have control and to downplay really anything that the person with dementia might be saying. environmental threats are other tactics that people use. That could be disorganizing belongings, making the home unsafe by creating fall hazards. And so we see this in different forms. We've seen people taking, like, if an older adult has a notepad where they have all their contacts listed, you know, that being removed. So those kind of like prompts for a person are not, you know, easily found. Hoarding would be another example, or we've even seen cases of dementia where a person has restricted, you know, the older adult's access to other rooms. Like in Miss Jones's situation, she was kept in a back room, in a dark room. She was not able to access other parts of the home, even though she wanted to, and even though she could. And part of that, you know, is to control the older person with dementia. We also see leveraging the relationship and manipulating confusion to manufacture a relationship. So this could be, you know, we see situations where a person with dementia is farther along in the disease process, and they may recall that at one point they had a husband, and then someone stepping in, like a handyman we saw in one instance, and you know, becoming or identifying as that person's husband, even though they're really not. We also were recently involved in a guardianship case where this grandson was allegedly causing harm to his, you know, 96-year-old grandmother, and the court, in doing its discovery, figured out this man wasn't actually her grandson. He was just someone who kind of like assumed the grandson's identity, but because he came from a similar background as the woman, he was kind of able to slip right in there. It can also mean leveraging a relationship that is real, like, you know, saying to a person with dementia, I'm your daughter, you have to listen to me. If you do this, you don't love me. So, you know, that would be another way of leveraging a relationship. I think this is your slide, Mom.
Yeah, so moving on along the wheel, I wanted to talk about legal maneuvering. So where we think about legal maneuvering, we think about legal tools that might actually be purposefully created to help people who may have some kind of impairment continue to manage their funds through a trusted person. So a power of attorney, which allows a trusted agent to make financial decisions and execute financial activities on behalf of the principal, the person who's appointed the agent, or a healthcare proxy, which allows an agent to make healthcare decisions on behalf of the person, or a will, which of course allows somebody once they've died to continue to effectuate their wishes about whatever they've left behind. Those are all tools that can be obviously a huge benefit to people with dementia who are experiencing cognitive impairment and may not be able to make these decisions for themselves. But they can also be used as very powerful tactics of power and control. So what we'll see is either, you know, somebody will trick an older person with dementia into signing paperwork that they don't even remember, or they don't fully understand what it is, and they'll you know, they'll have unwittingly signed a power of attorney, signed a healthcare proxy, signed a will. We've had clients who've signed all of these things and have been presented with documents and have no memory of ever having signed it, you know, and only kind of, you know, and don't even necessarily fully know the person who had them sign it, or don't even remember the person who had them sign it, but that person manipulated them into signing it in that moment. Or we'll have people who legitimately did select this person to make financial decisions on their behalf or healthcare decisions, but the person is then, you know, violating the fiduciary duty or the ethical duty that they've assumed, and are not using those tools in the older adult's best interest, but are rather using them to, for example, take the older adult's money and let the older adult's bills go unpaid, or to make healthcare decisions that are not in, you know, and not in line with the older person's expressed wishes, their values, their best interest, whatever they may be. Or of course, you know, executing a will that isn't a new will that isn't in line with the person's sort of long-standing expressed desires about what will happen to the things that they leave behind or the assets that they leave behind. And we see this also done informally, even when there aren't necessarily these tools in place. Somebody can manipulate the older adult's bank account, can withdraw money. We've seen people who, you know, who are tricked into believing that they owe money and will pay the same bill several times in a day or in a week because they just don't remember having already paid it, or will, you know, give their family member who's causing them harm, will keep on coming to them to ask for money for school or money that sounds like it's for a legitimate purpose, but they'll ask them for it a number of times and they'll receive, you know, many times the amount that the older adult intends to give or can afford to give, because they can't remember having given it before. So, and of course, when a person has dementia, they're even more reliant on the people who are around them, who, whether they like it or not, have assumed this caregiving role of helping the older adult with finances, with healthcare tasks, with managing their lives. And then, you know, even if the older adult feels uncomfortable or out of control or, you know, in some way isolated or is concerned about the power that this person has because of this role that they've assumed, the older adult with dementia might be afraid of changing things because they sort of then who's gonna help? Who else are they going to find to be able to help them? And they might feel very daunted because of their general sort of vulnerability coupled with the disease that they're experiencing of being able to find someone new and sort of recreate these caregiving relationships with a new person. Meredith, do I turn this back over to you now?
Yes.
Great.
Hold on, let me just make sure the slide changes. Okay. Okay, and then moving along the wheel, we have withholding care, and how we see this most often playing out is, you know, someone comes into the older adult's life and cancels home care services and promises that they're gonna take good care of them and then, you know, isolates them further and doesn't follow through with providing this assistance. It's also taking away medication or even actually over medicating someone to make them compliant and to make it so they can't report what's happening to them. It can also mean, you know, taking away memory care assistive devices like calendars, telephones that might be storing information. And then we also have minimizing, denying, and blaming. That might look like an older adult with dementia coming into your medical office and trying to voice a complaint, but the person who's harming them is saying, don't listen to them, they have dementia, they don't know what they're talking about. They don't manage their finances, she doesn't know what she's saying.
Meredith, sorry, I realized I only talked about legal maneuvering on the last slide. I didn't do the other two. Can we just go back for a minute?
Sure.
So sorry, I got carried away with legal maneuvering, but two more of tactics on this wheel that I just wanted to make sure we touched on. So threats and intimidation. So obviously that can be a tactic of power and control regardless of whether someone has dementia or not, but there are unique threats that are particularly salient with a person who is living with dementia. You know, threatening to put the person in a nursing home and they'll never get out because no one will believe them, threatening to harm the person themselves, to harm their pets, to harm their property, to, you know, if the older person has certain places that they keep things and they remember where they are, threatening to move them around or put them somewhere where they won't be able to find them, threatening to, you know, sort of sort of saying, you know, you need me because you can't manage on your own because you have dementia, or, you know, no one else is going to be willing to help you. You're just you're just a demented old man, like that type of thing, you know, can be particularly powerful. And finally, isolation. I mean, we've seen a number of cases where people who are causing harm may use the fact that the older adult has dementia to justify keeping cameras on them, listening devices on them all the time. And other people may accept that that's understandable because after all, they need to be watched for their own safety because they have dementia. But of course, this is a very powerful way of keeping control of someone to monitor them constantly. Controlling their communication, again, listening in on their phone calls, on their video calls, on their visitors, again, all under this guise of protecting them because of their dementia. And you know, just causing them to feel like they're rejected from society. They can't go out into the world. They won't be able to navigate, sort of, you know, creating this self-isolation because the person who is experiencing harm can begin to believe this sort of the negative things that the person who's causing the harm is saying. So now that we've done that, so I think, you know, the reason that we wanted to sort of really dive into this tool that we created here is because we really feel like these unique ways that power and control is exercised over a person who has dementia is really part of the reason that elder abuse shelter, a shelter specifically for older adults who are experiencing abuse, is so necessary and is so different than a shelter for younger people, a domestic violence shelter, a homeless shelter, because we have first of all, a facility where the medical needs that are unique to people who are experiencing cognitive impairment are dealt with by people who are expert in addressing those needs. And we also have professionals on our Weinberg Center team who are expert in these specific tactics and can really work with older adults who may have experienced these tactics on really trying to undo some of them, restore the older person to, you know, maximizing their capacity, figuring out ways to feel more powerful, more proficient, more independent. And by doing that, really finding justice. And we do that really in close partnership with the medical team and the clinical team, because gaining medical stability and maximizing independence when someone has cognitive impairment, those medical and social and legal components are so closely linked. So it's really a case for the need for shelter. And so I said before that one of our main activities at the Weinberg Center is fostering replication of our shelter program in communities around the country. This logo is the logo for the Spring Alliance. That's our community of practice for professionals around the country who have created models similar to our own. We now are in 17 states. We have 28 shelter programs in 17 states around the country and 2 in Canada. There's our website. That's a website just for our shelter community. And if you go to the next slide, like I said, each community has a slightly different model based on their own community's makeup, resources, and needs. So this is just a little graphic that we have that illustrates some of the different ways that the model of an elder abuse shelter has been executed in different communities. So the first one is ones like ours. So a program that's affiliated with one long-term care community or a continuum of care campus. So this is like ours, where our team is a program of the long-term care facility. We operate exclusively within the long-term care facility. Our admissions process, like Meredith said, is really inextricably connected with the overall admissions process at the Hebrew Home. And because of that, the niche that we're trying to fill is really for older adults who need this level of medical care, maybe not necessarily long-term, but at least for a particular point in their lives, and can receive it in tandem with these elder justice services. The second model is a model where it's really a community organization that is the one who are the ones that are creating the shelter program. They're the ones that are actually running the shelter. So that could be a domestic violence organization. That could be an area agency on aging. They work in the community, but they see this unique need for shelter, and they've decided to implement it. And where that happens, they often will partner with a number of different sites to shelter clients, and they therefore may accommodate clients with a variety of different levels of clinical need. So maybe they partner with a nursing home or an assisted living or an independent living, and they can accommodate clients who require that level of care. Maybe they partner with an independent living facility, or they partner with an SRO, or they use hotel rooms, and they're really catering more toward older adults who are more independent, but are still older and so have unique needs related to long-term housing, benefits, systems that they need to be able to access in terms of long-term safety planning and regaining stability. And then we have other models that are based on unique community needs. So one model that's up and coming is shelter programs that are actually operated by Adult Protective Services. Adult Protective Services, you've probably all, I'm imagining many of you have made referrals or had people on your team make referrals to Adult Protective Services where you perhaps are discharging a patient or you've seen a patient and you suspect that something is going on at home, but you can't quite put a finger on it and you think someone needs to follow up. Well, that someone typically in the community is Adult Protective Services. And when they often see this need and are on the front line seeing people who aren't safe at home. So in a growing number of communities, they're operating shelter programs. And those shelter programs can be open to everyone who qualifies for Adult Protective Services. So they may reach beyond older adults. They may also be servicing younger people who have developmental disabilities or other types of impairments. And they have a variety of locations where those people are physically sheltered to accommodate those needs, and Adult Protective Services has a case open throughout that length of time when the person is staying in shelter. There are other models that look similar or different. We actually are just finishing a 2-year evaluation of the shelter model in a number of sites. We partnered with the New York Academy of Medicine to do this. We were funded by the federal government, and so we'll be shortly coming out with a report on their findings around the need and impact of shelter and really recommendations on what's needed to take this model even more broadly and bring it to even more communities than it is already in, because as I hope we've already shown you, it really fills a unique need and niche that otherwise can cause people to really fall through the cracks in a very dramatic way with dramatic impact. Meredith, I think I'm turning it back over to you.
Yes, so we have a list of resources here that we think you'll find useful. The first is for Adult Protective Services. These are all the New York City numbers, but of course you could find, if you're not in New York City, you could find your local Adult Protective Services by going on your area agency on aging website. We also have listed the VET team's number. They're also just for New York City. That's the team that helped Ms. Jones. And again, they're this, virtual elder abuse ER out of Weill Cornell. We have our consult line number. So if you are working with someone who you think is experiencing elder abuse and you have questions, feel free to use us as a resource. You can call that number, and we'll brainstorm with our multidisciplinary team to see if there's a way that we can guide you or assist the older adult. Our referral number is also there as well. So if you know someone who is in need of shelter, you can call that number to place a referral and start the admission process. We also have a link here to our Elder Justice Resource Guide, which was created with the Weinberg Center and the court system in New York. And that's really, if you're looking for elder abuse resources, but you're not in New York City, that would be a good place to look because it will list everything. And I believe it's recently been updated as well. So all the numbers there and contacts are up to date. And lastly, the Elder Abuse Helpline for Concerned Person is a statewide resource. This isn't something that you would be calling, but if you're interacting with a family member of an older adult or a neighbor of an older adult, and they're expressing a concern about elder abuse, that's a good number to give them. They provide counseling and also referrals because, like the people witnessing the abuse, it may not feel empowered and may be distressed as well. So it's also to assist them. And I think that covers it. Are there any questions from the group?
Hey, thank you so much. This is Paula. If anyone has any questions, you can unmute yourself and put on your screen if you want. But I guess now I don't want to feel better or worse, because like, what are you supposed to do when, the dementia patient like clearly is demented and says things that don't make sense, and then their family's in the background going, like, how do you know when you could trust them? And honestly, like, my experience with APS has not been that great. And I've I basically use them as a threat for patients who are kind of self-neglecting. And I'll say, listen, if you don't accept help, I have to call APS, and who knows what they're going to do. Meanwhile, I'm thinking, I know they're not going to do anything, but I don't tell them that. So how do you kind of figure out when you do need to call?
That's a really good question, and I don't know that there's a clear-cut answer, but hopefully if you're working with the older adult regularly, you'll have like a good sense of what their personality is. I think it's also important to, as much as possible, like interview them alone without the family member there. And kind of like gauge their response by asking probing questions, but it is really tough.
And have you had success with APS? I mean, my experience is that they mostly give resources, and if, people are amenable, that works, but that they have not that much actual power. It's not like Child Protective Services where they can just like take you out of your house and put you someplace safe.
So I mean, I would say yes, we do. I think we're fortunate in part because we have like a developer relationship with them that if we're not getting a response, we know who to call. But yes, but we're also seeing like the worst of the worst cases, because those are the people who can't stay in their homes and are in need of shelter. So I think usually APS is very responsive to those cases.
I see. You think and when you do have that imminent threat, kind of that's I probably shouldn't say this, but I will. Like I've told like the fellows, like my experience has been, and I'm being mildly facetious, but not completely, like if APS goes to the house, like unless they're standing there with like a bottle, a tank of gasoline and like a lighter, like not much is going to happen. Like there really needs to be like an acute danger for them to really intervene. But maybe that's just the patients that I've called for. I don't know.
Listen, I think if we're using a world where we're comparing them to Child Protective Services, then I think you're right. I mean, just because older adults are not children. So, I mean, fortunately or unfortunately, when it comes to children, they don't have full rights. So ultimately, the state is responsible for their well-being when their parents are neglecting them, and therefore, Child Protective Services has a lot more power to take all different kinds of steps to ensure that they're not being neglected or abused. With an older adult, even an older adult where cognitive impairment is suspected, the assumption is this person has full rights. They have, which includes the right to live as they want, which includes the right to live with someone who's causing them harm. And unless it's really, even if it's clear that the older person has some degree of confusion or impairment, if they're conversational and they're consistent about wanting to remain in a situation that's unsafe, I think, APS has a protocol. They can try to petition for guardianship. Like Meredith said, if there is really an acute, imminent emergency that I think would be akin to your, metaphorically akin to your gasoline lighter situation, they can call an ambulance and have the person removed. But there has to be a pretty high threshold to do that if a person is insisting that they don't want to go. And if the person is, and they're going to apply, Adult Protective Services is the only city agency that can petition for a guardian on behalf of an older person. But that's an extensive process that involves long court filings and going before a judge. It's not something that you can, like Child Protective Services, where the caseworker can sort of make a call and remove someone. So, I think the whole framework is really different. Rightfully so, I think, when we think about sort of, the ethics of really an individual being in charge of their own life, but very frustrating when, as professionals, we know that the person is not safe and is not making choices that are in their own best interest.
That's a very good point, and I forget it sometimes, but I do also tell the trainees what my husband tells me, because he's a psychiatrist, and he said, listen, like some people make bad decisions, like, and they're allowed to make bad decisions, and like, so like, if someone is full code and they're not going to be resuscitated, or they get a feeding tube and that they're going to have aspiration and whatnot, like, so what I try to say, I used to get very upset, and then I realized it's not fair. Like, this is their life when they pick their proxy and they make their decisions. So my new philosophy, you can see how I relax myself when I do my new philosophy, is I inform and they decide. And like, as long as I gave them information, they want to make a stupid decision, that's on them. And what I consider to be a stupid decision. But I think it does get trickier when there's capacity issues, and potential abuse issues, because, do they really trust the system, and that's where it's so hard. But this was super helpful, really amazing resources. And I hadn't realized that this model, existed, so broadly. And I commend you on, for the work in doing that. And I literally, when I read the description of the topics, I'm like, shelter model. Oh, that's interesting. I guess they have like a geriatric section, in the homeless shelters, and it is so not that. So, so really kudos and thank you for all of the work and service that you do. And, we really, society appreciates it. And now we can help kind of, spread the word.
Thank you for having us.
Thanks and feel free to give us a call if you're seeing anything that you'd like to talk through or learn more about resources, or, just brainstorm. We're happy to.
That's awesome. Would you like to see my gas can and lighter? I have them right here. Just kidding. Well, again, thank you so much, everybody. The link for the CME is in the chat. If you have any difficulty accessing the account, reach out to Isaiah or myself. And really kudos and thank you, and keep up the good work. And there are a few people I think who can go to bed every night, even though you see crazy things. You can go to bed every night knowing that, like, you're helping people. So that's huge. There is a request about sending the slides. Would that be okay for us to send the slides to the attendees?
Yeah. Yep. I can send the deck out.
Okay. Awesome. All right. Well, thank you, everybody. Have a great afternoon.